quite as animated. Sorry, I have some self-awareness, and that's not my strong point. I don't have any financial disclosure or conflicts for this presentation. So, Dr. Hamilton, obviously incredibly famous orthopedic in New York, and said this only the astronaut in our society is more selective individual than a professional ballet dancer. And I've been fortunate in Houston to take care of some astronauts. It's a very similar population. And they're both dancers and astronauts are truly a joy to take care of. So for posterior impingement, the origin is really multifactorial. And a lot of this has been kind of covered already. You can have anatomic structures such as an osteogonum or sciatus process. You can have posterior talus fractures, osteochondral lesions. You can have overuse-related problems in posterior ankle pain, such as the FHL, which has been mentioned, is very common. Posterior impingement is a disease of athletes, essentially. So most commonly, it's runners that run downhill, soccer players, and of course, what we're going to talk about is dancers. And Nick Van Dyck talked about this back in 2000, and endoscopic treatment is much more commonplace, just like Dr. Cable. It was an open procedure for me for many years until I started doing the arthroscopic. So basically, the symptoms are from repetitive plantar flexion movements, and in ballet, that's the demi-point and point positions. And in those point positions, you can have 12 times your body weight of compressive force across the posterior ankle, which is a giant number. Even in our ballet dancers who aren't certainly 300-pound offensive linemen, that multiply your body weight times 12, and that's an incredible force. But also look at the talus, as they talked about so elegantly. The size of the talus gets the same force as the knee on the same side, with an incredibly small surface area relative to the knee. So same forces, much smaller areas. I talked about downhill runners, soccer, especially sudden direction changes when they're striking the ball with their forefoot. So sort of demi-point and point positions which show posterior impingement and compressive forces. So anatomically, there's osseous factors that can be involved. And when you look at a lot of athletes, you can have a posterior tibia that slopes a bit downward in the back. And so there can be an anatomic variant. This was looked at in clinical radiology a few years ago. And you can also have a small facet on the posterior calcaneus. So the important thing is, it's not always just the osteogonum. So people that have posterior impingement, you can't just say it's the little bone back there. And oftentimes, the bone is not symptomatic. And so while the sports doctors like to say that there is no hope without scope or arthroscopy, and as Dr. Cato mentioned earlier, we treat patients. We don't treat x-rays or MRIs. And so just because somebody has something doesn't mean it's necessarily the cause of their symptoms. So the osteogonum, you can see it. It's been reported, most people say it's between 70 and 14%. It's been noted in up to 25% of patients. It's bilateral and 50%. And an osteogonum is basically an unfused ossification center. It's a growth center that just never fused back. You can have a fracture back there that just goes on to not heal, but most of the time patients don't report a history of trauma. And so we get x-rays in everyone, and we're orthopedic surgeons, so we get x-rays because we can. And when you have x-rays, sometimes it's hard to tell. Is it fused? Is it not fused? Is that really an osteogonum? So you can also have posterior medial process injuries, and these are usually traumatic and usually related to someone that's landing on an inverted foot and has a subtalar subluxation or dislocation. So there's a lot of ligaments anatomy that has been looked at. There's the posterior inferior tibia ligament, which is part of the syndesmosis. There's also an intermedial ligament that can get thickened or hypertrophic. And then the posterior talofibular ligament in red, which actually attaches posteriorly to the osteogonum. So there's soft tissue anatomy and bony anatomy. The flexor house is long as tendon, which has been already discussed and described. It lives in a little fiber osseous tunnel. Sometimes you can see tears in the tendon, or oftentimes a low-lying muscle. You can see in the top MR scan. This isn't next to the fiber osseous tunnel, but you can see the low-lying muscle belly that occurs with the red areas along the FHL tendon. You can also see fluid around it, and that's been mentioned earlier. It's been described as FHL fluid is not necessarily an abnormal finding. You can see it on the normal MR scan. You can also see, like in the bottom MRI, there's synovial capsular thickening, and just a lot of synovitis, which is all that white fluid around the subtalar joint. So it can be not just bony changes, but also soft tissue changes. So presentation history, dancers often present with no specific injury. They could have had a hyperplantar flexion injury, but oftentimes it's just a lot of heavy dancing, a lot of point work, and they start having posterior ankle pain. Swelling, oftentimes it's interesting, the dancers will complain of swelling. And I don't look at them and see visible swelling. They know, look, it's swollen. So it may be painfully obvious, but I'm not a former dancer. They are very tuned into their body. And so I listen to them about certain aspects of their history that sometimes you can overlook in other football players, baseball players. The dancers are very tuned into their body. Prior injuries, I asked about lateral ankle sprains. I think that's important, especially lateral ligament laxity. Can contribute to posterior impingement. Recurrent instability is a real big problem. And then if they had prior treatment, right, if they had previous injections, I want to know that. So the pain is posterior. And they tell you just what was mentioned earlier. They say it's not their Achilles, but it's kind of deep inside there. And it can be posterior, but remember, people talk a lot about, people outside the dance community talk a lot about posterior lateral pain, posterior lateral impingement. Well, here's a patient where the osteogonum or the trigonal process with the small sigma grossus, you can see all the marrow edema that surrounds it. But look where the arrow is. The process is on the medial side of the Achilles tendon. So just because they have posterior medial pain doesn't necessarily mean it's not posterior impingement. So you can see how medial the FHL tendon is. So here's the FHL tendon here, and you can see how far medial it is. And so it's actually kind of variable in pictures. So the duration can be acute or chronic. Most of the time they come in and they've had pain for a while before they get to see me. Exacerbating factors, important to ask you what position do they feel it when they're dancing. But remember, it's not all, and I know this is a dance medicine, but it occurs in soccer players. It's actually been more well described in surgical treatment in other athletes, like soccer players, than it has in dancers. So is it ball strike, handling the ball, and ring plantar flexion, acceleration or deceleration? Thorough lower extremity exams, again, they've talked about biomechanics and the kinetic chain. That's really important. So hip to toe to that adequate turnout. This is actually a former principal dancer who used to ballet. And so I'm sure that they're cringing at the sight of his left foot and his rolling in. But I was able to accommodate for that. But you got to look, they have adequate turnout of their hips. You want to look at the entire kinetic chain. So it's interesting when you look at our professional football players in Houston, Texas, we see tons of flat feet. You don't see a lot of flat feet in ballet. Matter of fact, I don't know anybody that has really bad S planets in Houston ballet. Most have neutral arches or a bit of cavus. You can see swelling, you can see crepitation along the FHL. So if you're looking for posterior impingement, they'll tell you they have swelling. Sometimes it's not too swollen, but you want to examine the entire ankle and the entire kinetic chain. You want to compare it to the opposite side. That's why you have two. Usually one's normal. You want to palpate all the anatomic structures. So everything in these patients is right under the skin. It's not hard to feel pretty much everything. You can feel the FHL. Dancers don't have cankles, so which is nice, right? I mean, as an orthopedic surgeon, it's fantastic. When I go look at someone says they've got a high sprain and a 350-pound offensive lineman, that's really a difficult exam because my hands don't fit. So the FHL, already been mentioned earlier, you can have coexisting flexor-hallucis as long as changes end impingement, and it's been reported to be up to about 40 to 45%. So examination, got in the history, you know you're going through their exam. Plantar flexion, right, you take them through the full range of motion, obviously you want a standing exam like we mentioned. Forced plantar flexion, and inversion, which has been suggested to look for posterior medial ankle impingement, which probably I haven't seen much of. It's probably seen me, I just haven't seen it. And then you want to look at dorsiflexion eversion, just to make sure if they have posterior lateral pain, if they don't have a perineal tendon problem or perineal tendon instability. So this is a young and happy dancer. When I forcibly plantar flex his foot, you can see his face. Now look at my face though, I kind of like it, right? So that's sort of the difference. Okay, so here's something that's really troublesome, right? So here's a patient, you see has a significant anterior, right? So that's lateral ligament laxity. And they just think about it, and they showed some great, the one slide they showed of the patient that was on point where their talus, their anterior tibia talus was opening up in the front. If those patients are loose, that talus wants to slide forward, and so that can exacerbate posterior impingement. And if I had a dancer that had anterior instability and posterior impingement, that's difficult. So I will send that to Dr. Cable for sure. So this is, other things you want to look for, right? It's hard for me to try to get the toe to trigger, but the patients will get their toe to trigger for you. They've got to do some goofy things sometimes to get it there. So you can see it right here in the back. So it's typical stenosing tenosynovitis of the FHL. And what you'll see is a thickened sort of bulbous flexor hallucis longus that gets caught or trapped in that fiber osseous tunnel. It actually gets caught or trapped when the nodule goes outside the tunnel, and then when they pull their toe up, the dorsal it pops and it goes back into the tunnel. Just another one, and again, this is why sometimes it's hard to see for me to get them to do it. They got to be in weird positions that you can hear it from them. And again, I'm smiling. I like that kind of stuff. Functional activities, obviously, you have to stand on at any point. You have to stand on a point. When dancers make appointments to come see in the office, we routinely ask them to bring in their toe shoes if they have ankle pain, just because you want to have them stand on point, and or as they discussed earlier, get x-rays on point. I think it's great. So x-rays, we always get plain x-rays to start with. Get a standing ankle x-ray, and I think Dr. Cable's point's a great one when you're looking at anterior issues is a foot radiograph, anterior medial ankle impingement. You only see those osteophytes on the talus in foot radiographs. You don't see them on the ankle. Lateral and dentate pointer point, and that's dancers should bring their point shoes. And so this is kind of what happens, is you get this little nugget of bone that gets stuck in the back here. Again, it's a dancer with posterior impingement, and it's nice to see those posterior radiographs. So diagnosing MRI for me is the study of choice. This is one of our company dancers who had posterior ankle pain and did indeed have some posterior ankle synovitis, but he had a full thickness chondral defect of the posterior aspect of his talar dome, which is actually the majority of his symptoms. And so MRIs are great. We routinely use 3 Tesla MRI magnets. We just now got a 7 Tesla magnet method, so the detail is incredible. So you can see edema within the osteogonum, which I'll show you in a second. You can see FHL pathology, and like I mentioned, they mentioned in the earlier talk, fluid around the FHL can be normal. You can also evaluate posterior medial ankle impingement. So here's one posterior synovitis. There's a lot of fluid around the posterior aspect of the subtalar joint and ankle joint. You can see edema around the synchondrosis. So here's the osteogonum. And you can see this kind of lights up with edema, and the synchondrosis between the two is also hot. So this is more posterior medial change. So again, here's the flexor hallucis longus, and so this is medial. So this is posterior medial edema in the talus. So remember, posterior ankle pain, not always osteogonum. I mean, yes, you hear horse or the beats outside your window. It's usually a horse, but it's not always a horse. Sometimes you fool. Again, another osteogonum, small one, the synovitis surrounding it, and then gigantimus, really not a dancer. You're not going to see that. Well, you might see it in a very young dancer. You just tell them that they probably will never be a very old dancer. He's not a professional. So diagnostic CT scans, I think, are also great. They're better for bony anatomy, as was already mentioned. You can see fracture of the posterior process, and they're kind of helpful. They're very helpful actually if you're considering fixing it. This is actually a University of Houston football player that had a forced plantar flexion and had a fracture of his posterior process. And so you can see also subtalar dislocations. And again, this was a subtalar dislocation that occurred with an inversion mechanism. You can see there's just a lot of combination that's on the medial side of the talus. Bone scans, mostly historic. I couldn't find a picture in my archives for posterior impingement. But if you have a symptomatic osteogonum and you're really unsure, you get a bone scan. If it lights up, that certainly can point you in the right direction. Ultrasound, I think Dr. Cale's one was a great one, which is, she doesn't read them herself, she has someone there. If you have a great ultrasonographer, it's amazing. You can see some amazing things, but I don't have the skills, and they look like a bunch of wavy black and gray lines to me. But they're also helpful for injections. If you want to consider injecting along the osteogonum or around the FHL, which you need to do with caution, but you have to be careful, right? So I struggle to do these in clinic sometimes. So here's the FHL, and the little red cloud is the neurovascular bundle. So if you stick their tibial nerve, they will not like you, okay? And if you give them residual dysesthesis for a while, they'll really not like you. So you have to be careful, and I think ultrasound can be really helpful for these types of injections. Diagnostics can be, they can be helpful. You can inject the posterior aspect of the ankle joint. You can inject intra-articularly from the front of the ankle to see if they get symptom relief. You can do FHL sheath injections. You got to be careful. You're going to do intertendinous injections. In the hand, they inject trigger fingers all the time, right? We're really cautious in weight-bearing tendons of the foot and ankle. You don't want a tendon rupture. You certainly don't want an FHL rupture in a ballet dancer. I can get by with it in a football player. I can get by with it in a baseball player, but in a dancer, if you get an FHL rupture, you'll never repair it and they're done. So be careful. So non-treatment, basically it's doctor hurts when I do that. Don't do that. And they love it when you say that, right? So dancers don't want to take time off. There's rest, avoidance of activity, plantar flexion activity, icing, non-steroidal therapy, perineal strengthening, especially if they have any anterior knee stability or laxity, physiotherapy, taping injections. And there was a report about 20 years ago showed affected about 60%. Most of the time, once they have chronic posterior ankle pain, posterior impingement pain from the trigonum, I do all these things. And surgery is truly the last option. But at least in my practice, by the time they get to me, they usually don't. They've tried everything, I usually don't. So I bring myself so often. So surgical treatment is tailored to the pathology, and it's after failure of non-operative treatment. Posterior impingement alone, it's just an trigonum, posterior ankle arthroscopy. You can do it open or through a scope. Results are remarkably similar. Complication rates may be a little higher in the open approach. Dr. Cale's method is a great one, which is, the biggest issue for those is the sural nerve. And you get sural nerve problem. And the sural nerve is just one of those nerves where you look at it funny and it just acts weird. So posterior impingement with an FHL, open posterior medial approach. I've not really gotten to the point where I'm comfortable doing a release through the scope. The tibial nerve, as we saw in the other picture, is right there, and you just don't want to have those kind of problems. So again, posterior impingement alone, symptomatic posterior impingement due to an osteogonum. See it on the plane radiographs on lateral point view, edema lungs and fibrosis, as well as in the osteogonum. So I do a prone position. I do a marthoscopic, and I let the foot hang off the bed. And the reason I do that, they don't have more trouble than I do, but I have a nice round tummy that I can push against the foot, so I can move it up and down. And so that makes it easy, so I can push the foot into dorsiflexion with my body habits, should we say. Portals, you want to put it right next to the Achilles tendon, although there's a soft spot. You don't want to bugger up the tendon, right? So you want to be away from the tendon a little bit, but really right at the level of the fibula, just on the medial lateral side of the Achilles tendon. And basically you want to put the scope in. I put the scope in from the lateral portal first, and it's kind of in line with the first row. You don't want to get too far medial. You want to avoid the neurovascular structures. So you put the scope in, it's clear as a bell. So actually, there's nothing to see hard. Oftentimes, you can pop into the subfibular joint sometimes, but generally you got to kind of do a little debriding with your shaver. That's kind of what I'm doing here. And then as you start, you kind of see the osteogonum. Here's the subtalar joint. This is the osteogonum. I'm just releasing some of the ligament structures on the medial side with a little diver. And as you get there, you kind of start seeing it, and you can start removing it. You can do it in one big bite if you're lucky. Oftentimes, I got to take it in a couple of bites, and then you kind of got it freed up here. And here's the ankle joint. Here's the subtalar joint. And then when you're done, you have this kind of released posterior area. Your FHLs here on the medial side. And you can expect the ankle. So here's the back of the talus. You can certainly get back there and get the posterior medial osteochondral if you wanted to. And here's the subtalar joint posterior laterally. So you can see really well once you've got it all cleaned up. And I always look at the FHL, but again, it'd be great to come in here and just do a little medial release, try to release it. I'm just which makes me really nervous. I haven't done it yet. So just a quick one just to show you kind of what it looks like. So you can see how mobile the osteogonium is. That's the shaver. I'm just moving the osteogonium up and down. Here's the subtalar joint, the ankle joints up here. The FHL is going to be sitting right over here on the medial side. So pretty sizable one. You get dizzy, you can shake your head, and it kind of becomes clear at the same time watching. But that's kind of what you do. It's really fun. I mean, I actually think posterior ankle arthroscopy is easier than anterior ankle arthroscopy. So here's the FHL, and you can kind of move it up and down, and just make sure there's no. You can see how low the muscle is. There's the muscle belly in the FHL, and so you can imagine that they had a low line muscle would get caught or stuck back there. I still get an X-ray when I'm done to be sure. Early on in my practice, I had left a little nugget behind in somebody. That's really embarrassing when they come back to see you in the office and they have some discomfort, but it happens. If you have associated FHL, I go immediately. I think Dr. Cato showed a similar slide. Some of the literature reports have shown some really small incisions here. That makes me a little bit nervous, just because you're right around the neurovascular bundle. So basically you go in, here's the FHL. She's got some little bit of tendinopathy here, but you do an FHL release and you can go just around the other side and get to the osteogonium. Post-op care, I don't really put them in a boot if it's just impingement anymore. I let them just wait there in the post-op shoe. And again, I do the surgery and I try to do a great job for them, but we have an incredible team to help them rehab, and that's the key, right? And that's athletic trainers, physical therapists, massage therapists, Pilates instructors. It's everyone. You want them to be seeing everyone to get them back to their absolute fullest potential. Scar massage is important, and then return to dance is tolerated. Reports do suggest 8 to 9 weeks. 3 to 4 months is more where they're dancing completely pain-free in my experience. A little longer if you're going open than arthroscopic. So overall results are good, and so I think if you do open excision, it's been shown to be good in the middle taper at 38 patients. They had a few complications with some wound or incisional problems and a couple of keloids. That's kind of hard to predict unless they're previous keloid former. And so Chris Coetzee, very good orthopedic surgeon in Minneapolis, takes care of a lot of dancers. Looked at his open approach. Overall good results. Interesting, 76, very good to excellent at 12 months. 3 sural nerve complications. That just is something you'd like to avoid. 1 CRPS, which is something you'd really like to avoid. And then basically he said some patients were dead in the sad fact because it took so long to return to full dancing. So another thing that's important is patient expectations. Make sure your patients know they're dancers and it takes longer to get better than it does. I mean, I can get a soccer player back much sooner, and that's not because they're better athletes, it's because the demands aren't nearly as great as that in ballet dancers. So their demands are so great, sometimes it just takes a bit longer. That's it, okay? Thank you very much.